Hello and welcome to the Art of Being Human. I thought today I would take some time and talk to you about research, new research in diabetic care. And I think you're going to find this very interesting because there are new forms of insulin being developed. Insulin that maybe act as a blood sugar monitor, so all you have to do is take the insulin and then it monitors your blood sugar and releases according to the need that you have, and you don't have to keep checking all the time. There's all kinds of things on the horizon that can help monitor your illness and that will help you to control your illness. So I want to start first with insulin that you might be able to breathe in, inhalable insulin. Now this insulin that's being worked on, and this isn't the first time they've tried to do this. The last time they tried to do it was pretty unsuccessful, but what they're trying to develop is an insulin that you can breathe in. You inhale it, and the way that you do that is through some kind of a device that acts like an inhaler, and there are little cartridges. It's about the size of a whistle. It's not very large. The last time they tried it, it was huge, and it just didn't work out well. But if you have something about the size of a whistle, and you can put little cartridges in it, and the cartridges in the whistle have insulin in them, then you can put them up to your nose and breathe in the insulin. And that means you would not have to take injections. It's a fine powder. You would be breathing in this fine powder, and you use it through the inhaler, and the particles are very, very small. The advantage of it is the fact that it gets in your system very, very fast. Within a few seconds, it's deep in the lungs. Now I want to show you a picture of the lungs, a model of the lungs, so if we can just get this up. This is interesting, and I think it'll surprise some of you what the lungs actually look like. So these are the lungs. And okay, that's good. These are the lungs, and all of the blue areas are for the veins. All of the red areas are for the arteries. You have both in your lungs, and all of the white spaces are spaces that contain air. Now, usually we see pictures of the lungs, and they're small or medium size, and they have little things in them, little lines in them. But really, do you ever see something like this? This is a rosin cast. I got it from a medical book. It's a rosin cast, and everything's painted in according to whether it's red arteries, blue veins, or white air spaces. And who would have thought that your lungs have this much in them? They're massive. There's a lot of arteries and veins in your lungs, not just a few. And so I know when I had pneumonia earlier this year, I had pneumonia. And one of the doctors, I went to the doctors one day and they said, "Oh, don't worry about it, you don't have pneumonia." And then I was so sick. The following day I went back and I saw a different doctor, and he says, "I have to check those x-rays again, just in case you really do have pneumonia." And then he came back and he said, "You do have pneumonia." But it's also, a nurse told me, very, very hard to diagnose. And when you look at the massive nature of the arteries and veins in your lungs, it's no surprise to me that it would be very difficult to diagnose. It is difficult to diagnose. So within seconds, with this inhalable insulin, within seconds, it gets deep into your lungs. And when you get it into your lungs, it's only another 5 or 6 seconds and it's in the bloodstream. It's that fast. Now, usually when you inject insulin, it's going to be 10 minutes or so before you see a result, depending upon the kind of insulin that you're taking, depending upon how much you're taking. But this is inhalable insulin, goes right into the lungs, directly into the lungs, and from the lungs it gets directly into the blood system. And so therefore, it's like within a couple of minutes, or you almost can say within a few seconds, it goes from one to the other, and you have insulin in your system. So it's kind of amazing. Now, it's not for everybody. there are some people who can't take it. People who are smokers can't take it. The reason is because there's just too much lung damage from smoking. Asthma patients can't take it. And I expect that some allergy patients can't either, because you fill up, and that's a problem. COPD patients can't take it. Now, COPD stands for this. It's chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease, and it's COPD. A lot of people have COPD. They even have classes where you have therapy for it. When I was having heart therapy after my bypass surgery, I met a lady who was going in for her therapy after her whatever they were treating her for. They were treating her for COPD, and she said she got it from smoking. She'd smoked for years and years and years, and there was so much lung damage. She was finally, diagnosed with it, but she had to go in for treatment. Not only that, but it was like a class in how to handle it, just like when I went in for my classes after heart surgery. How do you handle it? What are the exercises you use? And so she did the same kind of thing, but of course it was a different class than mine. Mine was heart, hers was lungs. So people who have lung problems can't take it. They can't do it. But other than that, most people could. Now, I have a concern about it because of the fact that I'm afraid of residue in the lungs. You know, they were talking about being able to inhale the vaccines for flu. You know, instead of getting a flu shot, you could inhale the vaccine for flu, so you would get it in your system that way. But I was always afraid of lung residue, and it would pile up in your lungs. How do you know that what you breathe in your lungs is completely excreted? How do you know that? If you're breathing in a virus, or if you're breathing in bacteria, even if the bacteria are dead, and most shots the bacteria is dead, but you still get an immune reaction from it, how do you know that there's not some left in the lungs? I mean, I don't know, but I'm not a doctor. I'm not talking to you as a medical professional, but I am talking to you as a patient who's been diabetic for almost 30 years. How do I know there's nothing in my lungs that shouldn't be there? And if there's a residue left, then if it builds up and you get more and more of a residue, what's to prevent you from having breathing problems from that? Blocking off some of the cells and having breathing problems from that. That's my concern with it. But everybody's all excited about it. You breathe in your insulin. So who would do it? Who would be people who would be prone to do that? Well, it would be people who for some reason are fearful of injections or don't want to do injections. Most people, I was reading, most people who go on insulin, they postpone in the insulin. They postpone injections because they don't want to inject. And sometimes they postpone it for 5 years. People resist taking insulin because you have to inject it. Well, is there any other way to take it? Not unless you can breathe it in. You can't swallow it. You can't use insulin through a pill or something like that, because insulin is a protein. And once you get it in your stomach, it just digests. And when it digests, it's just like a food. I mean, it doesn't have any effect on the blood sugar at all. It just goes through the digestive tract like food goes through the digestive tract. The only way that you can get insulin into the bloodstream to lower the blood sugar is to do it by injection or use an inhalable. And so a lot of people who are afraid of injections might turn to this. Or people who use injections, they can develop a lot of scar tissue because of the injections. Now, I take 5 injections a day, and I do have scar tissue. And a lot of people have enough scar tissue, their bodies need a break from the constant injections. Actually, when you're taking injections for insulin, you're supposed to vary the site. They will actually give you a diagram of a human body, and they will shade off those areas that you put your injections in. And you're supposed to rotate that so you don't always have your other injections in the same spot. But I know if I'm eating and I'm sitting down and I need to take a shot, I don't necessarily rotate the injections. Oh, this part is right in front of me. I can see it. I don't have to half undress to get to it, so why not there? I know I went to a doctor who examined me recently, just on a regular appointment, and I had this big lump in my stomach. And he says, there's a lump there. And of course, I was aware of it. I could feel it. And I says, well, I was going to ask you about that. He says, it is a lump that's filled with blood. I says, well, how come? He says, it's because you've had so many insulin injections right there. It's collected its own blood supply. So you're really supposed to vary it. But after a while, you get scar tissue, you get lumps, you get areas where blood has come together. And sometimes you might just need a break from taking injections, and so therefore you would go to the inhalables until the scar tissue heals, or until it's safe for you to get back on injections again. So people who do that, they also might be able to get a lot of help from the inhalable insulin. So it is being worked on. I think that at some point it will be available. I don't think I would ever take it because I'm still concerned about residue in the lungs because of the problems with lungs that you might have. Breathing is important, you know, and I don't mind rotating the injection sites, even though sometimes I don't bother. And I can see the scar tissue build up, and when that happens, I will rotate. But you're supposed to rotate like almost daily so that you don't get a site that's too scarred up. You know, it is a problem if you're a diabetic, you're a diabetic for life. When you have been diagnosed, you're going to be diagnosed for life. And so you're going to, if you take insulin, now some people don't take insulin, they can manage it with pills and exercise and diet. But at some point, you probably will take insulin, even if you're a type 2 diabetic, because the disease progresses. And as it progresses, it gets worse and worse. And at some point, even if you're type 2, you probably will end up by taking insulin injections. That's something that is in the cards for most people who are diabetic. You have to think that even though you're type 2, people used to think that if you're type 2, then you manage it with pills and medications and diet and exercise. If you're type 1, you need injections to begin with. And they usually think of type 1 as being for children or young people or infants, really, and then type 2 as being adult onset. And that's what they used to call it, type 2 adult onset, type 1 juvenile. Well, they don't use the terms adult onset and juvenile like they used to. The reason being is you can get type 1 at any age. You know, you could be 55 and get type 1. Although it would be unusual, it certainly can happen. And juvenile diabetic, well, what does juvenile? Is juvenile always type 1? Well, it might be. But you see, you can get type 1 at any age, so why use the term juvenile associated with it? Type 2 is also any age. You see, we've changed the way that we look at it. But that's the situation with inhalable insulin, and I think it's going to come to pass. I think fairly soon it'll come to pass. Now, Lantus, I want to mention about Lantus. Lantus is this one right here. It's long-acting insulin. It's, I think, kind of a miracle drug. I have gotten more results and help with Lantus than I have anything else. And Lantus is long-acting. Humulog is short-acting, and that's this one here with the red cap. Now, Levemir is also long-acting. This actually has insulin in it. I haven't used it, and it has the cap on it, so it has to be refrigerated. So there are different companies that make them. Levemir is made by a different company than Lantus is made. I've taken both of them, but I have to say the Lantus for me, now I'm only talking about myself because different people will have different experiences, but for me, Lantus is much more effective than Levemir. It does a much better job than Levemir. Levemir does work after a fashion, but Lantus works better. But as I say, I'm only talking about myself. Well, Lantus, the patent has run out on it this year. That that means a lot of companies are going to be able to get in and try to make an insulin that's like Lantus, but what they want to do is make an insulin that's longer lasting. Insulin like Lantus is long acting. A lot of patients take it just once a day, but some people take it twice a day and they split it up. Most of it being in the morning and some of it at night, a lesser amount at night, but the goal is to take it once a day, and some people do that successfully. I split mine up, but it doesn't matter. That's what you do with Lantus, and it does have a long-term effect. So it only releases, it's almost like a time release. It releases so much per hour, so we do get benefits from it almost all day long. So the goal here is to make a new kind of Lantus, and it's called Toujeo. Oh, I'm going to spell that out because I'm not sure that I'm pronouncing it right. It's Toujeo. And it's supposed to be another version of Lantus that's supposed to release more slowly and last even longer than the Lantus does now. So that's another thing that's happening. And as I said before, insulin is a protein, so you can't take it. You have to inject it. So that's the next coming thing with that Lantus. Now, some companies are trying to develop an insulin that you take one dose of and it will last a week. One dose, and maybe they can do it. I mean, it's something that they are working with. The chemists are trying to develop it, and so what they do is that if you take it, if it works, and you take it once a week, it gradually releases itself. And when it releases itself a little bit at a time over all of the hours that are involved in 1 week. And that would be good if they could do it. But my concern would be, would you forget to take it again? If I take an injection and I only have to take it once a week, I can assure you that unless I write it down, 3 or 4 days are going to pass and I'm going to say, when did I take that now? Was it yesterday? Was it the day before? How long have I been on this medication? I do it now. You take this medication for 2 weeks. Okay, well, if I don't write down when the start date is on a calendar, by the time a week and a half is up, I can't remember when I started it. You know, and people get distracted. Their lives are busy and they don't remember things, so you have to write everything down. That might be an issue. And they're also trying to develop an insulin that's controlled by your own blood sugar. You inject the insulin and your own blood sugar tells it when to release. And that happens because it will be coded. And when it's coded and your blood sugar gets so high, then the coating is going to dissolve. A certain percentage of the coating will dissolve and it will release itself. And then when your blood sugar gets low enough so that you don't need it anymore, it shuts down. And it doesn't release itself. Every time your blood sugar goes up and you need insulin, it releases itself. So you don't have to check your blood sugar all the time. Like I'm supposed to check my blood sugar at least 4 times a day, and I usually do that. And sometimes I forget it, but usually I do that. But your blood would be the one that measures your blood sugar, and then it releases according to what your blood sugar is. Now that's a fascinating thing, and maybe they'll get that going. That's the plan. There is, and this is for sure on the market now. It's called Diabetic Sentry. It looks like a watch. And it wears like a watch, and it's not too bad looking. I've seen pictures of it, and it has sensors on it. So you wear it around your wrist, and the sensors are right there, and they measure your blood sugar to make sure that it's not too low. And if it gets too low, it sounds an alarm. Now, it doesn't measure if your blood sugar gets too high, only if it gets too low. So most people wear it, if they have one, they wear it when they're sleeping, and it'll alarm you if your blood sugar gets too low. The alarm will wake you up, and then you know you've got to eat some fruit or something to bring your blood sugar up. I don't know why they couldn't make a sensor that would check when you're too high and then alarm you that way too. But this is just for low blood sugar, and I think that's already on the market. Some people are wearing it. A few years ago, they tried to make a device that would measure your blood sugar high and low, and you wore it on your wrist. It actually went to market. I saw one, but I never bought one. And now it's gone out of existence because it was just hard to handle. But it was huge, you know? A watch that looks like this. 52, 55, 56 millimeters wide, really huge. And you wore it on your wrist, and it did have a sensing device, and you could measure your blood sugar and know what it was. 24 hours a day. It would measure it like every 5 or 10 minutes or something. I don't know if there was any alarm on it, but it would tell you what your blood sugar is. It would be a lot easier than stabbing yourself and checking your blood directly. But there were problems with it. It didn't work out quite like they expected, and it went off the market, so you could no longer get that. Now, there are some scientists that are trying to make an artificial pancreas. I'm gonna, you know, we're almost out of time, so I think I'm gonna start next time with this because I don't have enough to go through exactly what is being done about this. But the artificial pancreas is being worked on, so I'll close it here because we don't have much time left, and I'll begin next time with the artificial pancreas and go on from there in terms of new developments for people who are diabetic. So we'll close it here. Please join me next time.